Everyone, welcome back to my YouTube channel, and today inshallah we are going to be talking on peptic ulcer and Zollinger-Ellison syndrome. But before we go in, let me draw you some parts of the stomach that we are going to be focusing on. This is our fundus. This is our body. This is our antrum. And here is our pylorus. And this is the duodenum. So these are the parts of the stomach that we are going to be focusing on. And the problem that happens is we have imbalance between defensive and aggressive factors in the stomach. So let me show you imbalance. The scale is imbalanced. So here we have the defensive factors, which are low, and here are the aggressive factors, which are higher. So now what are these defensive factors? Let's change the color. Defensive factors. So these defensive factors include surface mucosal secretion, that is in the stomach, and also we have bicarbonate secretion. We also have prostaglandin secretion. We also have adequate blood flow. We also have rapid epithelial regeneration. So these are the defensive factors of the stomach. And the aggressive factors are what is going on? Aggressive factors, these are H. pylori, followed by NSAIDs, smoking, ischemia, bile reflux, which is also known as duodenogastric reflux. Okay, so now let's start discussing peptic ulcer in details. What is peptic ulcer? Peptic ulcer is an ulceration that happens at any part of the GI system. Ulceration at any level of the GIT, gastrointestinal tract, and this ranges from the esophagus up to the ileum. So now, what part of the GIT does it affect? Most commonly, we have the duodenum, which causes the duodenum, which we have 90 to 95% occur in its first part, and in the stomach more than 90% occurs in the lesser curvature. And this esophagus usually associated with what? Reflux esophagitis, while in the ileum usually associated with Meckel's diverticulum. In the jejunum is usually associated with Zollinger-Ellison syndrome, which we are going to see at the end of this lecture. Now, what are the risk factors? Now, the risk factors of this disease include, we have infectious, which includes H. pylori. We have age, which are more than 60 years of age. We also have stress. We have smoking, diet. It can also be hereditary, which involves number 1, blood group O. People with blood group O, and people with large parietal cell, and also people with who can't secrete their antigen into saliva and gastric juice. The antigen is the secrete their blood group. So under the hereditary, we have 3 things, which are the blood group O, number 1, and patients who are having large parietal cell mass, and people who can't secrete their blood group antigen into their saliva and the gastric juice. So now let's run and see how these factors manage to cause the disease. Number 1, let's take a look at H. pylori, the infectious one. H. pylori. This H. pylori is strongly very associated with peptic ulcer. It's strong association, and in 90% of cases it causes duodenal ulcer. And in 70% of cases it causes gastric ulcer. And usually in 50% of cases there are people who are more than 50 years of age in developed countries, while in the developing countries we have more than 90% of adults who are infected. Now, how does this H. pylori causes this disease? Let's see. This H. pylori is gram-negative bacilli. H. pylori was secretes urease. It was also secrete what? Protease. And also secrete phospholipase. Now, this urease and protease will lead to what? Breakdown of glycoprotein in the gastric mucosa. Whereas this phospholipase will lead to what? It will damage the epithelium first, and it will what? Recruit neutrophils. It will attract neutrophils. When these neutrophils come, they'll come in order to get rid of the H. pylori, while in the process they will lead to what? Damage of the mucosa, the epithelial cells. So when these neutrophils come, they will come and secrete what? Myeloperoxidase. When they secrete this myeloperoxidase, it will lead to destruction of the epithelial cells. This destruction will lead to inflammation, and this inflammation will make what? It will make the mucosa more susceptible to what? Acid injury, because the protection of the mucosa has been damaged. More susceptible to acid injury. So this will lead to what? Destruction, and finally ulceration, just the peptic ulcer. So this is how the H. pylori causes it is ulceration. In majority of cases, H. pylori infected people present only with what? Pangastritis, that is generalized inflammation of the stomach. Pangastritis. And in minority of patients, they present with what? Mainly antral predominant gastritis, which this antral predominant gastritis will lead to what? Hypergastrinemia, that is oversecretion of the gastric juice. So this hypergastrinemia will lead to what? Hypersecretion of the acid, increase acid secretion. Well, this increased acid secretion by the parietal cells will eventually lead to ulceration. So in majority of cases, usually they have mild pangastritis, and in minority they have antral predominant gastritis, and from there it will lead to hypergastrinemia leading to oversecretion of acid, and then this oversecretion will lead to ulceration. While in much lesser population, it will be what? Carpus predominant, that is the fundus predominant gastritis, which will lead to what? Decreased acid excretion, plus gastric atrophy. This gastric atrophy and decreased acid excretion will lead to what? Proliferation of other bacteria. In the stomach, and this will lead to chronic inflammation. This chronic inflammation will eventually lead to gastric cancer. So this is what happened. One of the 3 things that happen when a patient is infected with H. pylori. So now let's see the next causative agent. We have the NSAIDs plus aspirin. NSAID plus aspirin. These 2 factors, what? They causes 30% gastric ulceration, and they also cause ulcer in the small intestine, that is less commonly. They can also cause colitis and colonic strictures. So, how does this NSAIDs causes peptic ulcer? These NSAIDs are responsible for NSAID plus aspirin. They are going to inhibit cyclooxygenase 1 and cyclooxygenase 2. And the function of this cyclooxygenase 1 is what? Secretion of prostaglandin at the site of inflammation, while the function of COX-2 is secretion of prostaglandin in the gastric mucosa for protection. So automatically, when NSAIDs and aspirin inhibit cyclooxygenase 1 and cyclooxygenase 2, it means that the defense mechanism has been altered. So there will be decreased defense and increased ulceration. Now, this is how they cause ulcer. Now, the next thing is we have the smoking. Okay, so smoking has the ability to what? Cause increase in gastric ulcer. It causes increased gastric ulceration and decrease the rate of healing increase recurrence. That is, if you are smoking and you had this disease before, it will increase your risk of developing the disease again. Now, smoking, how does it cause this ulcer? Smoking is mainly tobacco. So this tobacco, when you take this tobacco, it will lead to what? Increase acid secretion, leading to what? And increase acid secretion, and also it will lead to decrease blood flow and decrease prostaglandin synthesis. So you see, it mainly affects the defensive factors very badly. Synthesis. And now all of this will lead to impaired mucosal defense, which will lead to ulceration, unfortunately. So now the next one is the duodeноgastric reflux, which I told you, it's also the bile reflux. So bile reflux happens due to what? Pyloric sphincter incontinence. So this will lead to bile acid reflux, and this bile acid reflux will lead to what? Damage of mucosal barrier, leading to chronic esophagitis plus increase acid secretion, and this will eventually lead to ulceration. And this is how the gastric reflux causes ulcer. Now, what are the clinical pictures of this disease? Clinical picture or presentation of this disease. Number one, we have pain, which is epigastric, localized. It can be pointing, the patient can put pointing sign, meaning the patient can put his finger and localize the point of the pain. This pain happens 15 to 30 minutes after a meal. In gastric ulcer, while in duodenal ulcer, it happens within 2 to 3 hours after meal. In duodenal ulcer. And this pain, when if it radiates to the back, in between the scapula, plus no response to antacids, it indicates pancreatic penetration. Meaning the ulcer has gone into the pancreas. And now the other symptoms are, we have bloating, we also have vomiting, fullness after meal. Now, what are the aggravating factors of this disease and the relieving factors? The aggravating factors include, number one, smoking. Like I said earlier, it's one of the risk factors. Alcohol. We have eating in gastric ulcer. While we have missing meals in duodenal ulcer. Then we have excessive intake of coffee and tea. Now, what are these relieving factors? The relieving factors include antacid, except if there is perforation to the pancreas. And we have milk also. We have vomiting if the patient is having gastric ulcer. We also have food intake. If the patient is having duodenal ulcer. Now, what are the alarming symptoms? The alarming symptoms of this disease. The alarming symptoms, number one, we have anemia, and we have loss of weight. We also have anorexia. We also have melena, indicating bleeding, and hematemesis. We also have swallowing difficulty, and finally we have when it is recent and progressive, sudden onset. Okay, now what are the complications of this disease? The complications of this disease include hemorrhage, also perforation, penetration, like I mentioned earlier. We have pyloric obstruction too, and finally malignancy. How can we investigate a patient with peptic ulcer? The investigations include: number one, we have the endoscopy, a barium meal, and finally test for H. pylori. H. pylori, which is in two ways. Either you do fecal antigen tests or you do urea breath tests. Now, how can we manage these patients? Management. We have three ways. There is the general. We have the acid suppression. We have the cryptoprotective agents, and we also have surgery. 4 ways. Now let's look at them one by one. The general, just avoid all the risk and aggravating factors mentioned earlier. And number 2, the acid suppression. Acid